So let's just dig a little deeper in Jack's clinic. So at Jack's clinic, you can do physiotherapy, you can do chiropractic, and you can do massage therapy. You can do acupuncture treatments, you can do a registered dietitian, you can do cold laser therapy, you can do nutrigenomics. They do motor vehicle accident claims, they do virtual rehab, they do custom orthotics, they do PNF and mobility treatments, they do custom braces and rehabilitation. They do decongestive therapy. They do instrument-assisted soft tissue mobilization. They do personal training. That's coming soon. This was very interesting. A new thing that they started doing is they do IV therapy. So they hook you up to an IV, and they actually call it their new IV therapy lounge. They do the cold plunge therapy. Oh, sorry, that's coming soon. They do shockwave therapy. Also, apparently, they might actually help with Peyronie's disease, like ouch. And they do yoga. And they also, to make it, so this is the #1 chiro clinic. And they also, to make it really, really convenient, they actually direct bill to 27 major private insurers, just to make your life much easier. It'd be interesting to see how many people do different therapies depending on how they come in or what they actually start off with. I don't even know, there's so much. I think there's more therapies than there are 27 major private insurers that they direct bill to. But where am I going with this? Because the story just got better. So under chiropractor, chiropractors are trained to assess, diagnose, and treat people affected by injuries, illness, disability with their spine, neck, pelvis, joints, nervous system, concussions, manual therapy, assistive devices, exercise prescription, education. Yeah, that's all good. Now get this. This is where the story gets better. Some clinics require that you get an X-ray. We don't. X-rays are only needed when they're absolutely medically necessary. Like, it sounds like this is like their unique selling proposition. Hey guys, we're not like those spinal reconstruction, spinal correction guys that actually get an X-ray. We don't use X-rays. If you're a chiropractor and you're a specialist, I want to see the spine. It's called diagnostic imaging. I use X-rays to diagnose, right? But they don't. And it's kind of this USP. Some clinics require that you get an X-ray. We don't. It's very interesting. I want to tell you a story. So my son Rode, is an awesome ski racer. He is actually taking some time off and he's in school right now because he's still rehabbing an injury. This is an injury that started many, many moons ago. Rode last year, this time he had just come back from Austria. So he's on a US ski team that is out of Lake Placid, New York. So Rode was actually living in Lake Placid, New York this time last year. And his coach is Thomas Vaughn, ex-coach to Lindsey Vaughn. So very, very reputable coach. But Rode had this constant knee pain that just seemed to be getting worse and worse and worse. And so we went through the top docs here in Ottawa, the top sport docs, the docs that actually do the Senators, do the Red Blacks, do the 67s, do the university teams. And so it looked like there was some extra bone. He did have Osgoods, like he's had Osgoods, and now there's some extra bone. We weren't sure exactly where the extra bone is, but he had this massive swelling of the fat pads around the ligaments in the knee. All the knee ligaments are stabilized, and they were stable and intact. Why? Because a whole slew of CAT scans, a whole slew of X-rays, a whole slew of MRIs. We don't wait to get into MRI. As soon as we want an MRI, we get in. And so why did they do all that stuff? Is to diagnose, so they could prognose, and they can actually set up a treatment protocol. So initially, after we did some PRP here in Canada, And some of the fat pads started to reduce a little bit with swelling. And this was PRP under ultrasound. Why? Because they want to know exactly they're hitting the right spot to be able to inject the PRP. And then we had sat down with one of the top knee surgeons here in Ottawa, and they said, yeah, I would do a little bit more conservative because he's trying to get into his racing schedule that starts in December. And so I would do like PRP. So we did PRP. It worked a little bit. We didn't want to cut into the patellar tendon because it would just weaken it, and the rehab could take up to a year. And so we went from Canada, and because Rode was already in the States, we started doing some investigating into the States right across. So the biologics and regenerative medicine in the States are about 15 years ahead of Canada right now. So we talked to clinics in Arizona, California. The Arizona clinic was connected to a regenerative clinic in Colombia. So we were talking about going down to Colombia for a procedure, but we found that one of the top guys, and this guy is in New York City. So this is a doctor. So this is a road surgeon in New York City, right on Madison Avenue. This is Rode after his 32 injections of high density PRP into his knee. He's on a saline drip just to get some of the fluids back because they were taken out and put back in. This room is right over Madison Avenue. So you're looking at the New York City skyline. They have everything in house. The surgical suite is in the clinic. They have all the latest technology, everything, and it's super, super, super high end. But before you go to this clinic, you have to have all the CT scans, all the X-rays. And why? Because they use X-ray for diagnosis. Okay, they use X-ray for diagnosis. So Rode went through the procedure and he actually got some relief. And then, but it was still coming back. Not as bad, but it was coming back. So then he headed back down to New York City 8 weeks later. So New York City in November, New York City in January. At this point, we were trying to get him back to this racing schedule, but it didn't look like it was going to happen. Dr. Sussman said, actually, sorry, this is not Dr. Sussman. Dr. Sussman is his other surgeon. This surgeon said that, you know what, he would suggest that we search out something that can look at the mechanics, because he thinks that it's the mechanical swelling that's taken place, irritation. And so we say, okay, do you have anybody in mind? He says, well, there's this new procedure called a 10X procedure. One of the leading guys is in Boston. So then we go from New York City, then we head to Boston. So this is a lateral knee taken X-ray. Why do we take an X-ray? Or why do they want to take an X-ray? Is because they use it for diagnosis. Not only for diagnosis, but what the game plan is going to be for prognosis if it doesn't happen, for expectations set and timelines set for rehabilitation and anything that needs to happen. So you can actually see here is that you can see the extra bony fragment. Okay, you can't see the fat pads. You can only see the inflamed fat pads on the CAT scans and on the ultrasound. And so the bony fragments near anterior tubercle causing the friction type symptoms. So that's the culprit right there. It's in the tendon, but you can see that some of it's out of the tendon. So we're not sure exactly what is, like, how much in, how much out. So Rode undergoes his first procedure with his microsurgeon in Boston. And this is him on the table. And this is him. The lights are off because the surgeon has actually got a dual probe. One is a high frequency ultrasound. The other one's suction and irrigation. So bone is getting chiseled away and actually sucked up at the same time. This guy is a top leading specialist in the procedure that was actually originated from the Mayo Clinic in Minnesota. And it's amazing. And if any of you guys joint issues due to extra bone, I'd be willing to get into detail with you, but it was really awesome. So November 2021. So Rode has to rehab. So he rehabs for the next 8 to 12 weeks. Swelling comes down. He gets a little bit of strength. And we actually see bony fragments within patellar tendon near anterior tubercle appear to have decreased in size when compared to right lateral knee dated November 21. So doing why post X-ray? Because it's for diagnosis, for comparison. It's actually where we are and where are we going. And so this is him in August. So we see that there's a reduction in size, but we still see there's a lot left. And so symptoms of decrease, but we're still not there yet. So in August 2022, Rode is back in Boston for another procedure. This is his surgeon there. Everything is in-house. But before we go to this, this is the afternoon surgery, but we spent the morning at the Boston Celtics Orthopedic Surgical Clinic. And why we went there is because we wanted up-to-date special X-rays in different actually angles, so we can get an idea of where the bone is actually literally situated behind the patella, inside the patella, both. So he can determine how aggressive he can go based on where the bone is. So how it works with this Boston Celtics clinic, no matter what you go in with, you can, so we're in there, we're the first ones there, filling out our forms, and there's, so the Rode's there for knee, okay? And there's other people coming in for low back, for, you know, hip, for shoulder. And before you ever get to see this surgeon, what they do is they do X-rays. So you go right from the waiting room right into X-ray. It doesn't matter if you have previous X-rays. They want up-to-date X-rays. They have their own formula for X-rays, and you're getting X-rays. And if you're doing it knees, or if anything that's bilateral, you're getting both done so they can compare. So that's right across the board. If you don't want the X-ray, you don't see the specialist. Okay, so we get the knee X-rays. The X-rays are sent to this surgeon. The ortho surgeon said, listen, if the microsurgery doesn't actually work, it's working now, but if we can't get it all, then you're going to come back to see me and we're going to do the full-blown surgery. Long story short, the new X-rays are even better. So Rhodes been rehabbing. Now he's in school. He's not racing for right now. So the bone's completely gone. And I actually talked to him this morning and I asked him this question. So Rode could not actually squat before because of the irritation. Now Rode's squat, and he couldn't do a full leg press either. Now Rode actually reps 8 to 12 reps for 4 to 5 sets at 225 with the squat, ass to grass. And he actually also, he can push, he reps right now with 7 and 8 pounds on the press, 8 to 12 reps, 4 to 5 sets. So we just thank God that, and the expertise from these experts, that they were able to really get in there, do what they do. And so where am I going with this? Well, you know, I got Alan. Alan came in a couple of weeks ago and his posture was brutal. Okay. His posture, he shuffles steps. He actually was so excited about being in their clinic that he showed up 3 hours prior to the report and he took 3 naps. So literally the report was at, well, actually probably 2.5 hours. Report was at 10. He shows up at 7:30 in the morning and he naps. He's 89 years old. He can hardly walk. He's bent over, like super, super big, huge hump, anterior carriage, the whole bit, and shuffle steps. You can tell he's losing function to his legs. So poor posture leads to serious spinal degeneration. We know that, right? For every inch forward of head posture, the weight of the spine increases by 10 pounds, Kapanji, right? And then we just posted this, Hum Club Chiropractic, but if you punch in Hum Club Chiropractic, you're going to actually get the Jack's clinic. Why I call him Jack? Because he appears to be Jack of all trades and probably a specialist in none of them. Just to let you know, that's why. But we're not Jacks of all. So why I want to take an X-ray is because I need to diagnose. I need to prognose. I need to get a feel for what's exactly going on with his spine. So for every inch forward, an extra 10 pounds. Well, how many inches forward do we have? Like whatever, like 5 inches forward here. Is this serious? Well, is this serious? That's the question. Is this medically, clinically, or chiropractically necessary imaging? Absolutely. But it depends what you see. It depends what you do with it. It depends what you specialize in. We specialize in spine reconstruction. We want to see the spine because it gives us a massive amount of diagnosis. We can actually have an idea of this has been here a long time because there's bone remodeling. The disc, the beautiful disc, it's not because of his age. This is the 89-year-old disc. It's beautiful. This is bone on bone. It's not beautiful. It's serious. It's clinically significant. That's why we actually use clinically significant warranted X-ray, right? Why do we do that? Because we know that the loss of cervical curve, that the structural damage will also lead to eventually neurological damage. You can't have structural damage over time without having neurologic damage. In spine, in this specific area, progressive kyphosis of the cervical spine resulted in demyelination of nerves and neuronal loss due to chronic cord compression of the spinal cord. So what we know is we got massive amounts of extra pressure to the lower neck area. That's why his C5, 6, 7 being destroyed. We know that also there is progressive demyelination because of progressive kyphosis, okay? And kyphosis over time only gets worse. And we also know that, you know what? At this level of C2, the spinal cord rests in the spacious vertebral canal. However, at C4 through C7, the broadened end plates of the vertebral bodies have resulted in canal stenosis. We know that there's canal stenosis, but not only do we know that there's canal stenosis, we know that there's cord compression. We also know that there's a lengthening of the spinal canal. Therefore, we know that there's actually a tethering and a tensile stretch to the spinal cord. And it says here, this probably had clinical significance to the individual. I'm telling you right now, this is having clinical significance to Alan, okay? And this is from Atlas of Common Sublications of the Human Spine and Pelvis. This is the first edition. It actually came out in 97, 98. We got the edition right off the bat. This is what changed the way we did things. This is what made us fall in love with, you know what? I can change curves. I can actually have an impact, not only clinically from a mechanical standpoint, but a neurological standpoint, from brain to body via brainstem and spinal cord. Billy, 10 years old, May 2021. She comes in, and I can tell she had a really bad posture. She got checked because her mom wanted her to get checked because her mom started to realize that she had bad posture. Posture is the window to the spine. So is bad posture enough to actually justify X-ray? Absolutely, but it depends whether you do correction or not. If you don't even adjust the spine, then you don't need to see the spine apparently. But if you adjust the spine and do spinal correction, you have clinical significance and it's warranted to take an X-ray. Billy came in without any symptoms, just bad posture. I took an X-ray. I'm going, hey mom, look, there's a kyphosis happening. What we know is, like, you know, for every inch forward, like, so she's a 1.5, 2 inches already at the age of 10. She's got an extra 20 pounds. What I can predict, prognose, mom, is that if she doesn't have any pain right now, but I guarantee you she will, and she will over time. But I'm more worried about the structure leading to neurological problems, because what's going to happen is that with this reversal, is I can predict that C5, C6 is going to get blown out with spinal degeneration, spinal remodeling, which is going to, right now, there's already tethering to the spinal cord at this point because of the kyphosis. And over time, there's going to be a demyelination of the nerves and neuronal loss. Okay. Well, doesn't start care. Billy, 11 years old, October 2022. Now she actually has symptoms. She has massive headaches, massive neck pain, and full spine pain. And this is a year and a half. She's gone from a 26 millimeter anterior carriage to a 40 millimeter anterior carriage. And what we see is the kyphosis got worse. So now what we know is that what she's going to do is head from a reversal as a phase 1 into a phase 2. And what we're going to get into phase 2 is note that the pons and brainstem are tethered against the posterior surface of the dens and transverse ligament. Introduction of any flexion, i.e. if you increase the kyphosis in the vertebral column, this will cause further tethering. So she's gone from tethering in 2021 to further tethering in 2022. Increased interspinous space indicates lengthening of the canal. Advanced disc degeneration is evident at the most subluxated and structurally stressed part of the cervical spine. With the reversal, we know this is a load moment. It's the most structurally stressed spine from a biomechanical standpoint. C5, C6 is going to blow out over time, guaranteed. Okay. Leah, so it depends what you see, right? Leah, 15 years old, she comes in and is like, yeah, she's got a little bit of a start of a kyphosis. Her symptoms, massive amount of symptoms. She has Tourette's syndrome. So Tourette's syndrome, she comes in and she gets referred in from somebody who said that Dr. Quirk actually might be able to help. When I see Leah's spine, what I actually see is Serena. Serena had Tourette's syndrome. She couldn't go to school or play with her friends anymore. And the reason why is because as a 7-year-old, she was diagnosed with Tourette's syndrome, depressed, and no longer in school. As a 7-year-old, she actually was on antidepressants because the Tourette's syndrome was so incredibly severe. Now, don't believe me, you can go watch the video. Okay. And then in the background here, you can actually see her post X-ray here with a beautiful curve, and she doesn't have Tourette's syndrome anymore. But this story actually is even better, because how Leah got referred in is because here she's 7 years old. Now she's in her mid-20s. She works with Leah's mother. So Serena, who works with Leah's mother, is the one that said, hey, I used to get Tourette's syndrome. It's because I had this reversal in my neck. I got my curve back, don't have Tourette's syndrome anymore. You should go see Dr. Quirk. So that's what we see. So it all depends on how you use X-ray, how you diagnose, how you prognose, and which your outcome measures. And if they are spinal reconstruction, your post-X-ray, your pre-X-ray, if we were in a surgical realm, people would be all over this. Right? But apparently over 50% of chiropractors in Canada don't want to see X-rays, and over 50% of chiropractors in BC apparently say that chiropractors shouldn't be seeing X-rays. It's ridiculous, because what I see, okay, is I look into the future and I can actually use X-ray in March 2022, and I can see Serena's story. I can actually predict what I'm after. I can tell whether it's fully correctable. I can tell the timeline and the prognosis. I can tell what's happening structurally. I can tell what's happening to the spinal cord and the nerve system as we get the curve back. And from March 2022 to September 2022, things are better. And not only that, is actually Leah has now decreased between 40 to 50% actually of Tourette's syndrome. Why we do this is also because I know exactly how to actually, lower the tractioning, but it turns out she hasn't been tractioned because she when she has her Tourette's episodes, it's hard to stay on the tractioning. So we modified the tractioning. We're going rolled up towel, which is much more comfortable in the lower neck area. It's a very, very hard towel, and we're getting amazing change, 40 to 50% decrease in Tourette's syndrome. Amy, April 2009. Okay, so I was just reflecting on this. I've never not taken an X-ray on somebody, though. If they're pregnant, I don't, but as soon as they deliver, I do. And if they're over 4 years old and they have bad posture or subluxation or something I found clinically, I'm going to want to take X-rays structurally to see the structure, because I could diagnose and prognose, and I can tell the timeline of correction it's going to take, and whether full correction is even possible. This is Amy, 2009. Amy, you got a reversal. That's what's causing your neck pain. Amy, your reversal's worse on C5, C6. Amy, that's stretching, lengthening the spinal canal. Amy, that's stretching your spinal cord. Amy, it's causing tethering of your brainstem area. Amy, as this blows out, you're going to have major symptoms in the neck, head possibly, and for sure, usually the arms. Amy, you should start care. We need to correct this. She doesn't start care. 2 weeks ago, she comes in with her, can't move her neck. Okay. Haven't seen her in 14 years. Can't move her neck. Okay. She's holding her the arms are up like this, totally disc bulge symptom, right? She's stretching. She's holding her neck, walking around like this, can't move. She's bawling. She's got 3 kids now. April 2009 to October 2022. So what's happened? Further kyphosis, further tethering, further structural damage, further remodeling, further spinal stenosis. Look at this. What blew out? Well, 5-6 blew out. Okay. 5-6 blew out now. 13 years difference. Look how much damage. What phase 1 to what phase would you advance? Phase 2 will be soon into a phase 3 at that specific area in 13 years. Now, the reason, okay, you can't know about X-ray if you don't take X-ray. We actually we adjust all of our patients by looking at their X-rays. So the docs at the clinic, we look at hundreds of X-rays actually a day, because of the amount of adjusting we do. We look at hundreds of x-rays a day, including all of our new patients. And we've been doing this for 25 years. Or going into 25 years of spinal reconstruction. We've seen thousands and thousands and thousands of x-rays. And that's why we take x-rays, because we're able to diagnose, we're able to prognose, and we're able to get correction, and we're able to change people's stories. Because if not, this is what Amy looks like, okay? We got the tethering, we got the stretching, we got the compression, we got the stenosis. And if this is not corrected, down the road, she's gonna look like Alan. And that's why we take x-rays. Pascal?
Ed, after that, I don't know if I have anything left to say. I think you nailed it all. I'm done.
It's all good. You gotta make us look smart though.
I love the passion. I love the passion. Okay, so here I'm just gonna share my screen here. So building exactly on what Ed said, we have to take x-rays. And there's a huge battle that's happening in our profession. Sorry, let me just get this going as I'm talking. There's a huge battle going on in our profession. We have, like Dr. Ed mentioned, 50% of chiropractors who don't want to take x-rays, who think that x-rays are only necessary when it's medically indicated. And that's because they are treating the patient, they are treating the person in a medical model, right? Only wanting to see the person 4 to 6 times for back pain and so on and so forth. They don't even know what to do with x-rays. And so again, this year we had asked the Warrior doctors, what did you guys want to see in terms of information, or what kind of presentations did you guys want us to cover? And one of the topics that was mentioned was radiation hormesis. And so I thought radiation hormesis tied in perfectly with the, I guess, present environment as to what's happening in our profession, this battle of reducing x-rays, only taking x-rays in red flag cases. So today we're going to be talking about, radiophobia versus radiation hormesis. What is radiation hormesis? Is there research that supports this idea that radiation could be beneficial for the human body? And then we're going to look at some of the literature that's come out on that topic. And I want to break down, how did we get to this area of being so fearful of x-rays? That linear no threshold model, why does it exist? And then what is the current consensus in the scientific community regarding that linear no threshold model? Okay, so let's dive in. So radiation hormesis. So radiation hormesis, it's a phenomenon that is beneficial to health as long as the exposures are in the hermetic zone. In other words, some radiation is beneficial to us as long as that radiation dose is within what's called the hormetic zone. Okay, and so that hormetic zone is, we'll talk about what those ranges are. When you have a low radiation dose in the hormetic zone, it does cause damage to the DNA. Okay, so specifically, I did say that correctly. That low dose radiation does cause damage. But that damage, when it's in the hormetic zone, what happens is it stimulates the body's adaptive protection systems. So it upregulates things like programmed cell death, cell senescence, the body's immune system. And what we're seeing is there's an overcorrection or an overcompensation to repair not only areas that were damaged, but the body then repairs more damage than was created by that low radiation dose. So in the end, after they've gotten that radiation dose, they are actually repairing more tissue damage than was there initially. And that is so important to understand. That is the whole basis of radiation hormesis. And so now, based on that, you're starting to see treatment of different human conditions with this low dose radiation. So things like cancer and degenerative diseases. There is a gentleman named Dr. Cutler, who's a radiation physicist. I had the privilege of seeing him speak at one of the CBP annuals. And basically what Dr. Cutler was telling us is he was starting to treat Parkinson's patients. He's successfully treated Parkinson's patients and Alzheimer's patients by putting them in a CT machine. So he's using a CT scan, not for a diagnosis. He's using the CT scan to give the patient a low dose of radiation to be able to successfully treat these degenerative conditions that are happening in the nervous system. Pretty cool stuff. Then we know that there was also Dr. Lobrick. He was the one that looked at the DNA strands. So he was the one that specifically looked at DNA double-stranded breaks in patients after they got a CT scan. So he counted the number of breaks that happened following the radiation dose in patients that got a CT scan, and then they remeasured those breaks between 5 and 24 hours later. And what they found was, in that time frame of 5 to 24 hours later, they were actually counting fewer breaks than were there initially. hence confirming the theory that yes, after that radiation dose, there is some damage, some low-grade damage, but the body is overcompensating by not only repairing the damage, but they are going back beyond baseline in the reparation. And then the other research that has come out recently that supports this whole idea behind radiation hormesis and longevity with low-dose radiation, Dr. Lemon and his colleagues put out a research where they put mice in CT scans. So they put a mouse into a CT scan or multiple CT scans, and they looked at the longevity compared to controls. And what they found was the mice that were getting this low dose radiation were outliving their controls. Pretty cool stuff. So what's the opposite of radiation hormesis? Well, that's radiophobia. And that's the paradigm, the model of healthcare that we've been practicing in the US as well as in Canada. In Canada, Dr. Quirk alluded to it, that there's this battle that's been going on in BC. The British Columbia Chiropractors Association, or the college there, had hired Dr. Cote and Dr. Corso to do a rapid review of the literature, and their review of the literature comprised of 8 studies. And based on those 8 studies, they said there was no data to support routine clinical x-rays, and that chiropractors should limit the use of x-rays unless, we thought there was a fracture, a tumor, infection. So those quote unquote red flags. You're seeing that push in the US as well. The American Chiropractic Association came out with guidelines within the past few years that were called choose wisely. In other words, only x-ray when it's medically necessary, because the x-rays can cause harm to people and they have no benefit to the clinical application of chiropractic care. That is the perception of the people who fall into this realm of radiophobia. Okay. And so radiophobia is the assumption or hypothesis that all radiation is harmful, regardless of dose level. The linear no threshold model assumes that high dose radiation exposure, this is data that came from Nagasaki and Hiroshima, so atomic bomb survivors. They used atomic bomb survivors to create the model that then guides how we take x-rays in clinical practice. I think that is so important to understand. We base our x-rays off of atomic bomb survivors. Okay, they built this linear no threshold model, which assumes basically that all radiation is harmful. So they took those radiation survivors and they built like a statistics model, and they regressed that back to 0. And I'll show you how they did that in one of the coming slides. And so shockingly, no one has actually ever studied low dose radiation, such as we would give patients with CT scans and x-rays, to see if there is a negative effect. It's just been assumed or hypothesized based off of atomic bomb survivors. The other piece to the information that's really important to understand why we adopted some of these protocols of radiophobia, there was a Dr. Herman J. Mueller, who had done the fruit fly experiment. You might remember this back from your chiropractic college days. In 1926, he took fruit flies and he exposed them to high dose of x-rays. And remember, think about the size of a fruit fly compared to a human being. And he was blasting them with radiation. And his conclusion, his Nobel Prize research, was saying that these fruit flies were getting sort of genetic drift. They were getting genetic mutations that were going multiple generations. And so based off of his data that said that these x-rays can cause genetic damage, genetic, I guess, mutations for multiple generations, you take the atomic bomb survivors, and then now you have this model that is very, very phobic of any type of radiation whatsoever. Interestingly, years later, they found out that Dr. Mueller's Nobel Prize research on these fruit flies was actually never peer reviewed by anybody. And secondly, now that people are going back and looking at his data, they're finding that his research was actually flawed and incorrect. So there's a plethora of research out there on radiation hormesis. I'm not showing you all of it. I'm just showing you the articles that you can get from the CBP nonprofit website. So if you go to cbpnonprofit.com, I like to show you guys where I take my information from. All of these articles are available. You just click on the link and then download the PDF. So right now, Dr. Paul Oakley, Edith Harrison, and colleagues have produced 16 different articles written by the CBP team. And these are all supporting routine x-rays in clinical practice for all the reasons that Dr. Quirk mentioned, but also helping to debunk the myth that the linear no threshold model is what we should follow. And furthermore, supporting the possibility of radiation hormesis through low dose radiation. Okay. All right, so here, let's draw this. Let's show you guys how they came to this. Whoops, not laser pointer. We want my pen. So here is a graph representing or comparing the linear model versus the J-curve or Hermetic model. So on this axis, you have your dose of radiation. So think about increasing dose. So from 0 is no radiation up to a high dose. And then up here, we have more cancer. So the incidence of cancer, obviously all the way up to, we'll call it death. But they're just saying higher rates of cancer mean more mortality. Now the graph starts midway up where it says normal here. This is very important to understand because we have a baseline. We have an average value of the incidence of cancer in our population as a whole. I'll use a random number, call it 5 per, 1,000 are going to get cancer. It's probably much higher than that, but there's a baseline value. And so for us to argue, or for anybody to argue that radiation is going to increase cancer, it has to be above the background level that already exists. So basically what they do is you start your graph from this normal level. And then they take, I'm going to put dots. So they take all of the dots, the survivors from Hiroshima, and I'm putting all these little dots, right? So this is how you build a regression model. You plot all your data points, thousands of data points onto a graph, right? So all these little red dots are different data points. And then what they do is statistical model just says, let's put a line in there and let's draw that line, let's regress it, and let's keep going all the way back to zero. So they took this high radiation bomb survivors up here, and then they make a model and they bring it back to zero. And they say radiation is bad, radiation is harmful, radiation is cumulative. That was the linear no threshold model that was built. That is what we base our protocols on still as of today, but things are changing. So now we look at current research. So I just showed you guys this, the atomic bomb data. But in 2012, this gentleman right here, or I should say maybe it's female, I shouldn't assume it was gentleman, Osaza and his or her colleagues reviewed that data. Now that they've had Hiroshima bomb survivors for 75 years, they've gone back and looked at the data and said, actually, these data, same thing, were improperly calculated and improperly plotted. And now that we have a longer time frame to look at these survivors, it's actually better data because we have a longer outset or time frame. And so what he said is, she said, let's just say Osaza said, let's get rid of this model because this is incorrect. And as a matter of fact, when you compare some of the survivors today, they are actually surviving longer. They have lower rates of cancer compared to the norm. And so Osaza said, this is actually what it should look like. It should be this Hormetic J curve where within a certain dose, we have a reduction in cancer and a reduction in mortality, all the way up to a certain dose where you're back to the same as your baseline, zero equivalent point. In other words, once you've got the dose that's this strong, you're back to the same baseline of cancer. In other words, it's not harmful, but it's also not beneficial. Anything above that dose, though, you can see does have that linear model where you increase in dose, you automatically increase your cancer or more of a lethal dose. And Dr. Cutler, who I alluded to earlier, also reviewed this data. He reviewed this data, but then also took data from Chernobyl because he took the data from the reactors that blew in Chernobyl. And so when he looked at the survivors from Chernobyl and he looked at the survivors from the atomic bomb data, he also came to the conclusion, and here is his purple graph. So his dotted line would be that normal incidence rate. And based on their exposure, he calculated the amount of exposure. This is the graph that he came up with. So up to a certain exposure, there's a maximum benefit, all the way up to your zero equivalent point. So when you overlap and you blend the data from Chernobyl and Nagasaki, you find that people that were a certain distance away from the explosion. So those, like, imagine those that were right next to the center of the core of the explosion or the bombs, they were highly exposed, high levels of cancer and death. And then as you went further and further away, there was that zone where they got a dose of radiation that is actually letting them live longer and reducing their cancer rates. So that's what Dr. Cutler came to the conclusion of. And his calculations are that the zero equivalent point is 1.1 gray, or also as 1100 milligray, because we're going to talk about our X-rays in a little bit, and we're going to talk about them in terms of milligray. So at 1100 milligray or more, that's where you would start to see the induction of leukemia. And he used leukemia because it would be one of the most sensitive cancers based on blood cells and probably the easiest to induce. Okay. So 1100 milligray is our point above which in a single dose where you would see that type of, I guess, harmful effect where the linear model would then come into play. Okay, so here, this is absolutely amazing. This came out, this is from Shared Health. So Shared Health is the body that regulates healthcare in Manitoba. So I received this memo last year, September 2nd, 2021. Anybody that practices in healthcare, orthopedics, medical doctors, anybody that would be taking or looking at X-rays got this memo. And here's what it said. Okay, so Shared Health is following a decision that was evidence-based And it came from the Canadian Association of Medical Radiation Technologists, the Canadian Association of Radiologists, and the American Association of Physicists in Medicine. And they are telling us that the scientific consensus on the risks associated with low levels of radiation used in diagnostic imaging has evolved, changing the way we look at routine shielding practices. For example, there is no evidence of heritable genetic effects in humans from radiation exposure at diagnostic levels, basically debunking the Nobel Prize work from Dr. Herman Muller. Okay. Modern X-ray imaging systems also require far less radiation to produce diagnostic images, blah, blah, blah. Basically, they are telling us stop shielding patients as of October 4th, 2021, because there is no harm to the diagnostic imaging that we are taking. So even in the medical mainstream healthcare, we're seeing this change. Yet for some reason in our profession, in chiropractic, we're back and forth about let's reduce X-rays because it's harmful for patients. And that's one of the main arguments that the, I guess, radiophobic camp is sort of hanging their hat on. So I think this is super important for you guys to know that there is a move in the scientific community worldwide understanding that diagnostic imaging is not harmful to patients. There's no genetic effects. We are well below the threshold of inducing cancer, yet somehow in our profession, politically, we're still battling whether or not we should be taking diagnostic imaging on patients in the absence of red flags. And so it's not just our profession. Obviously, we have to address patients' concerns because patients are going to come in and they have been indoctrinated with this dogma of radiophobic concerns. And so we have to be able to communicate to them on their level and help them understand that those radiophobic concerns should be reduced. And so when a patient comes in, you're not going to be starting to draw the linear no threshold model and talk about the atomic bombs in Hiroshima. You have to be able to talk to them in terms that they're going to understand and quickly break down their concerns or help them feel comfortable with the diagnostic imaging. And so one of the easiest ways is to help them understand that they are going to get much more probably background radiation just from where they live. This is a very easy one. So background radiation exposures, they're inescapable. We have them in any area of the world that you live in, they're going to vary. So from the lowest, it's 1 to 2 milligray per year to up to 260 milligrays per year. So you could tell patients that, hey, 1 to 2 milligray, that's probably the amount of radiation that you're going to get by doing the diagnostic imaging in our clinic. So even in the lowest background radiation place, you're going to get as much background radiation just living somewhere in 1 year than you would from our exam today. The other one I love to use is to tell patients that the amount of radiation that they're going to get is equivalent to a flight Chicago to San Francisco. And so you'd ask them, hey, are you going to omit your flight and not travel or not get on a plane because you're scared of the amount of radiation that you're going to get from traveling from Chicago to San Francisco? Most people would say no, just to help give them comparables of something that's tangible and they can understand. So up to 260 milligrays per year in some areas. So that'd be like the equivalent, depending where they live, of getting 130 to 260 sets of X-rays. Let me say that again. So some areas, background radiation, they're going to get 130 to 260 equivalent of X-rays per year. And so as doctors, though, you might be thinking, okay, well, maybe those patients have higher levels of cancer or other, health outcomes that are negative. And as a matter of fact, no, there are no health risks that have ever been documented with these higher levels of background radiation. And guess what? As a matter of fact, there are only benefits. People who live in these levels of higher background radiation have actually been shown to have lower levels of cancer and lower levels of lung cancer, specifically in areas that have higher levels of radon. I know, like in Winnipeg, there's a big thing, get your basement checked for radon because, being exposed to radon can cause lung cancer. Well, as a matter of fact, those who are exposed to higher background levels of radon have lower levels of lung cancer. So a lot of this stuff is completely counterintuitive to what we have been taught over time. The second concern that people have, well, doc, I understand that it's low level radiation, but isn't it cumulative? And it's trying to help them understand that it's not cumulative. And I think that one might be a little bit more challenging to break down that paradigm to your patients, but it's helping them understand that there are plenty of good reviews now that are showing us that by no means is the radiation dose cumulative, especially when it's below that 1100 milligray, that non-lethal dose. And so when you're in that low radiation zone that you get from ionizing radiation, not only is it not cumulative, it has that positive effect where it's stimulating the body's protection mechanisms, where it's actually helping and getting the repair systems moving to actually push the patient in a healthier status as opposed to being cumulative. And so as far as we know, based on the research, it's about 24 hours, right? 5 to 24 hours based on that research from Dr. Lobick and all, that had done the DNA double-stranded breaks following the CT scan. So it's about 5 to 24 hours. So when you're talking about a dose, you're talking about a dose within 24 hours. And so the radiation that we're giving them within 24 hours is not even close to being harmful or lethal by any means. And so here's an example too, if we want to put it into a perspective. I think for you guys than for patients, but this was another article written by Dr. Paul Oakley and his colleagues, 5 reasons why scoliosis x-rays are not harmful. And I hear this a lot because I do work a lot with scoliosis. Parents come in and say, well, I don't know if we should get more x-rays because my daughter's already had a bunch or my son's already had a bunch because they have scoliosis. So let's talk about this for a minute. The number of x-rays that they might get over time, right? And so on the low end, a patient might get 10 x-rays if they have scoliosis. It's mild. They've been managed or monitored throughout the medical system. If it's a more advanced or severe, they would have potentially 50 x-rays over the course of their lifetime. So if they have 50 x-rays over the course of their lifetime, their absorbed dose would be 25 to 50 milligray over 50 x-rays. 25 to 50 milligray. Remember, I said that threshold for inducing cancer was 1100, and there are other more conservative estimates that are 700 in one dose in 24 hours. So if you think about that dose, and you think about that dose of 50 x-rays over time, you realize very quickly that we are so far below the threshold of causing any damage that it's almost ludicrous to believe that it could be harmful for the patient. And then when you want to start talking about hormesis, the doses that are beneficial to actually help boost the immune system, cancers have been successfully treated with low dose therapy, exposing patients to a total dose of 150 rad or 1500 milligray over a 5-week period. So look at that, 1500 milligray, that's actually above the threshold to induce cancer, right? But they're saying over a 5-week period. So for example, they might break it up into 300 milligray doses or 500 milligray doses. So if it was 300, once a week for 5 weeks, 300 is well below our threshold here, but they're getting this total dose over 5 weeks and they're successfully treating cancer with it. So again, that's showing you that the dose, the poison is in the dose. If it was 1500 milligray all at one shot, it would be above that threshold. But in smaller doses, it is beneficial. And so I'm bringing this up because the reality is we are probably well under the ability to even help patients enhance their health via hormesis with radiography in our clinics. In other words, we're not giving them enough of a radiation dose to be beneficial, right? Unless you're x-raying them like 300 times in a week, then maybe you would stimulate their immune system. But unless you were giving them 300 lumbar series in 1 week, you're not stimulating their immune system. Okay. And so there needs to be further research to clarify exactly what level we're starting to see those protection mechanisms. But right now they're saying somewhere like 300 milligray is protective against breast cancer in a dose, 500 milligray are protective against secondary malignancies. So again, with your x-rays, and maybe if you take full spine series, you're at, I would say tops 10 milligray in your clinic for assessment. So you're well below the magnitude of inducing a hormetic effect. Okay. And then here's another point that I thought was really cool that should be brought up because it affects us all, is when you look at, if they take studies, I guess epidemiology studies, where they just look at people that work in low radiation environments, such as dock workers, actually radiation technicians. So it directly affects us because if you're taking your own x-rays, you would be considered like a radiation technician. So those that are occupationally exposed to low doses of radiation have lower levels of cancer than those that have less exposure. So in other words, you are exposed to low radiation all the time in your x-ray room when you're x-raying people. Those technicians in x-ray clinics, those dock workers who are exposed to low grade radiation do not have higher levels of cancer. They actually have lower levels of cancer. So again, when you start looking at epidemiology there, you start putting 2 and 2 together and saying, maybe there's something to this low dose that's giving us a benefit long-term. So then obviously Dr. Oakley and colleagues have put out this paper to try and rebut a lot of what's happening with the ACA's Choosing Wisely guidelines, what's happening in BC. Is talking about why we should be taking x-rays in clinical practice routinely, right? So here is a great article. It's in the Annals of Subluxation Research through Dr. McCoy, so you can find it there, or just click on the link in the CBP nonprofit page. And here are the 10 reasons, so 1 through 10. So let's go through these. No harm to the patient. So if we look at the current data, we know that there's no harm to the patient. So that argument should be off the table when people are talking about not taking x-rays, because there is a large consensus saying that there is no harm from low dose radiation. Contemporary spine methods necessitate it. And like Dr. Ed was talking about, any type of contemporary care for joints of the body, like his son getting the knee x-rays, you need x-rays to be able to properly diagnose, prognose, and give treatment to your patients. X-ray information leads to better patient outcomes. Just look at all the dental studies. Those that are doing corrective work have much better long-term outcomes at 1 year and 2 year follow-up. Incidental findings are important. I'm sure you guys have all had those incidental findings where you look at an x-ray and go, oh, there's a compression fracture there. Oh, there's severe degeneration. These cases where the clinical presentation does not meet what you find on the x-rays. But these incidental findings are absolutely going to change your care plan, how you adjust, how you care for that patient, because they are so important. I myself had a patient that came in one time with a floating dens in his neck. And thank God, because I don't necessarily take x-rays just because of pain. I take routine x-rays if there's postural issues and so on and so forth. He had a floating dens in his neck, right? And so if I hadn't taken that x-ray and I had just whacked and cracked as fast as I could without doing a proper clinical exam, I could have caused him much more harm than just taking the x-ray. Increase patient satisfaction. When we're starting to survey patients actually want to have diagnostic imaging. They want their health professionals to take a diagnostic image to look at what's happening on the inside, because it helps them understand their diagnosis. They want that confidence that you have done the most you can to complete a thorough examination to know what's happening with them. Right? You probably have all seen it in your clinics too. I have tons of patients when I tell them we're going to take x-rays, they're like, thank you, doc, because the last person I saw didn't take x-rays. They just laid me down on the table, cracked me, and said, come back and see me when it hurts again. They want a thorough examination so they can see what's going on. Satisfies your medical legal liability concerns. Obviously, this is a lot more important in the US, where it's a litigious society. But just like I mentioned with my patient with the floating dens, this stuff is so important for you to be able to also protect yourself, protect your license, so that you can keep practicing for 20, 30, 40 years. Costs are minimal. One of the arguments we hear all the time is, from people that are trying to avoid x-rays, is that chiropractors use x-rays so they can rack up the charges, so they can make more money. Well, that's a terrible argument, because most of us either, one, give the x-rays away, or are charging not even close to enough for it being worth our while. We charge $100 in our office to take the x-rays. By the time the x-rays are taken and they're noted and so on and so forth, it's probably at a loss for the amount of time that we're putting into it. And so we're not even charging for repeat x-rays either. And so the argument can't be used that you're using x-rays to make more money, because most chiropractors are doing them at low cost, specifically because they're just trying to do them to give the patient better care. Alternative methods don't give us biomechanical information. CT scans and MRIs are great for when there's soft tissue damage. Well, CT reconstruction with the joint, but still, these are done supine. And so if they're done supine, they're not great for us biomechanically, because they're not giving us any information about how the patient is walking and standing day to day. So x-rays are better. And then lastly, the possible patient health enhancement via hormesis. And I say possible because, again, it needs to be proven as to whether or not the very, 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 very low dose that we give patients in our plain film radiography, if it's enough to stimulate the hormetic effects. We still don't know that yet, right? And so in conclusion, that should be what you guys take away from it. So we're talking about the low dose radiation treatments. They're looking at the level of radiation that is given in a CT scan, and we're an order of magnitude below that. So not only is it not harmful, we have to be careful that we're telling, when your patient comes in this afternoon to your clinic, don't tell them, hey, I'm going to boost your immune system with my x-rays, because it's possible we're not even giving them enough dosage to boost the immune system yet. Okay, so be very careful when you propose that. And then lastly, number 3 is understand that we should all be talking the same language, and that we should not be avoiding x-rays, because 1, they're not harmful to patients, but 2, contemporary spine care in chiropractic, a proper thorough assessment requires x-rays. It guides your decision making, it guides your path, it gives us continuity to be able to measure patients over time. So that's all I got for you. As always, there's a coupon code if anybody wants to order dental rolls for the next 2 weeks. It's 10% off. You know the drill regarding my contact information. Dr. Ed, anything to add in closing?
Yeah, I just want to thank you, like really, really just thank you, because you help us believe in what we do, and you help us. And I mean, I know you're part of a greater also, with Dean and Don, and a greater heritage, let's say. And I just want to thank you for taking the time, because I don't know if you guys know, but we don't pay Pascal to do this. This is out of his heart. And I just want Pascal, like you're really, really saving lives. That's what it boils down to. It's really you're saving and transforming people's stories and saving lives. And we just wanted to just thank you for that. It's just it's much appreciated.
Well, it's a two-way
And
street, Dr. Ed. I appreciate the opportunity to do it. I love doing it. And it also helps me up my game to be able to present and be part of your group. So likewise, thank you very much for having me.